I'm very pleased to be able to talk about this particular topic. Having seen patients like this in the clinic and having tried to make sense out of some of the literature over the last 2 weeks or so and putting together these slides, I can tell you that there's a lot more information that has not been presented or is not being presented by me today. And I'm going to try to cover some of the issues that are still ongoing. I think there are some that have become more clear as time goes on. And it's just a matter of learning what still needs to be learned. First of all, there are 3 different clinical presentations of CNS lymphomas. The first is called primary CNS lymphoma, also which is usually of a non-GCB subtype. It almost never relapses in a systemic fashion. So it's very clear that that is a very different disorder than is secondary CNS lymphoma, which can occur at diagnosis when you have both systemic and CNS disease. Those are very rare cases, and they are often of GCB subtype, and those are the ones that happen to be also double hit, usually fit into that subgroup. They have a reasonably good prognosis when they receive secondary therapy, as for number 1, when they receive primary CNS lymphoma therapy. And you may find that during some of this presentation that I will refer back to that particular relationship that we often give therapy for secondary CNS lymphoma as if it were primary CNS, using data that we've learned from primary CNS. And then finally, CNS disease at the time of relapse, which is another kind of secondary CNS lymphoma. Those are also abbreviated. You'll see from now on, I'll abbreviate it as CNSL, which has become a standard format to use and a standard abbreviation for this particular disorder. Those can be either GCB or non-GCB, but they have a very, very poor prognosis, and we need better treatments for them. So this SCNSL relapse has occurred synchronous with systemic relapse in most cases. Getting isolated disease is very rare, and having leptomeningeal disease as a solitary site is very uncommon. It is usually parenchymal in nature. Relapsed or refractory disease also has a very poor prognosis, which is very different from primary CNS lymphoma, where a significant number of patients can actually be cured of their disorder with modern treatments. We don't understand very much about prognostic factors as yet, and detection of relapse also remains unclear as to how to do it the best way, even though there have been manuscripts that have said that flow cytometry with concentrated CSF and doing PCR might benefit the diagnosis. Therapy for solitary first relapse in this disorder has mimicked that for PCNSL, as I've mentioned before. And the roles of stem cell transplant, radiation therapy, and CAR-T are still unclear, although they're better defined for PCNSL, at least the stem cell and radiotherapy are. And new agents are under investigation, and this is a rare disorder, making studies difficult. I want to discuss a little bit about primary sites of involvement and specific sites at the high risk of CNS relapse. All of these that I've shown here have been associated with CNS relapse. And it is true that that renal involvement is now accepted, and the CNS IPI is being the most common site of disease which might indicate a CNS relapse. However, there are other authors who have come up with very different opinions, and testis was for a long time thought to be the most the disease that's most often associated, but it's not. Probably, and all of these are in certain circumstances and have been reported to be adverse sites of involvement predicting CNS relapse in the past. Marrow disease was also identified, but large cell lymphoma may have been confused with Burkitt at that time, or lymphoblastic lymphoma in some of those studies, and whether marrow is really involved with CNS relapse is not quite clear. We do know that it is a common feature of double hit, at least in the very beginning, and as many as 40 patients can actually have marrow involvement in some series. More than one extranodal site, however, appears to be accepted as high risk from some of the original studies that were done. There are others who have reported it, but Dr. Van Biesen from our center was one of the first to confirm that number of extranodal sites and a high LDH is all you need to have in order to diagnose or predict CNS relapse. These are specific sites at high risk of CNS relapse. And unfortunately, although some of these have received CNS prophylaxis, and you can see on the left-hand side the number who have this site involved in this particular review of patients who received RCHOP21 or RCHOP14. The number.
Professor, sorry to interrupt you. There is a lot of fluctuation in the sounds. Yeah. Yes.
Okay. And so the number with CNS prophylaxis is shown in the middle. And unfortunately, that did not seem to prevent CNS relapse in most of those cases. So it's very difficult at this point in time to figure out exactly what the real risk is of CNS relapse given any particular site of involvement. Although I think now we have to accept that renal is, but notice that I'm going to be, and when I show you the rest of these slides, you'll see that somewhere around 5% to perhaps 6 or 7% in most studies, as low as 3%, is the risk of CNS relapse in patients who are considered to have, quote, high-risk disease. In this study, CNS prophylaxis was at the investigator's discretion. These are results by the progression-free survival by the IPI just for progression-free survival in patients with large cell lymphoma. You'll notice that the R-IPI, which is the revised IPI, which was invented after rituximab became available, that a group that is considered poor risk was identified who approached that level of about 50% survival that we were interested in getting below to identify a poor risk group of patients, but it doesn't hit that. So neither of these particular scoring systems helped very much in helping us figure out whether a patient should receive intrathecal therapy or other kinds of chemotherapy other than R-CHOP. This is a multivariate analysis of prognostic factors in NCC and IPI. And I just want to point out, for the most part, that the LDH is split out into 3 different groups, and you get a point for having a high LDH, but if it's over 3 times upper limit of normal, you get 2 points. Age is also split out into 4 different groups. And if you're over...
Again, the mic is fluctuating, your voice.
Okay. If you are, let's see if just using the screen helps. If you are over the age of 75, you have a much higher risk of developing disease or having more points in this particular system. Specific sites of extranodal disease were each afforded a particular point, and that includes marrow, CNS, liver, or GI tract, or lung. Any of those 5 will give you an extra point. So you can have many more than just 5 adverse prognostic features. Notice that number of extranodal sites is not a part of the NCCN IPI. These are scoring systems that were used to figure out the using the IPI in the NCC and BCCA cohorts, which were 2 programs that were used to determine patients. I just want to point out something that I would love you to be able to understand. Look at the low, intermediate, and high intermediate risk groups. Those 5-year overall survivals going this way and this way are very similar between the NCC and IPI and the IPI. They don't really help that much in helping to make us understand a little bit more about which groups should or should not be treated with higher dose therapy. However, if you get down to the high-risk group of patients, you can see that the NCC and IPI does have a lower or a group that has a higher risk of developing of relapse. And the patients who also they have also relapse as well as overall survival are less in those patients. But it is a smaller number of patients. Only 8% fit into the high-risk group, as opposed to 14% in the high-risk group by the IPI. So are we over-treating or are we under-treating when we use the NCC and IPI or the regular IPI? I don't know the answer to that. The same that I observed just now is also observed with the BCCA cohort, the patients from Canada. There are other comments about the low-risk patients too, but they all have survivals and progression-free survivals that approach 90% or greater. So I'm not particularly concerned about those patients. I'm more about those high-risk patients and how to better identify them. There was one study that was presented in Clinical Epidemiology, so it's a statistical paper that most of us would not have reviewed. But investigators in this analysis reviewed 46 publications that reported results of 55 different models that have been described for prognosis of a diffuse large B-cell lymphoma. And there were issues with these models in that various statistical methods were used. There were small numbers in some studies. Most of them were not validated. And when they were, the IPI, the NCCN IPI, and the RIPI were used. The NCCN IPI performed well in most of these studies, however. There were some nomogram studies, a handful, that tended to do better than the NCCN IPI because they had better discrimination and calibration in their statistics. However, one cannot hold up any of these other analyses and say, this gives me a better idea of who's going to develop progressive disease of diffuse large B-cell lymphoma. For the time being, I think we have to choose the one that we think might be the most easy to use and the most reproducible. I think either the NCCN IPI or the RIPI, which we don't use very much, are the two that we probably should be using because the IPI was invented prior to rituximab's development. I do want to show you this particular analysis. This is the CNS IPI. And notice that at the bottom, I've pointed out that extranodal involvement in more than one side is not, I want to repeat that, is not an adverse prognostic factor by hazard ratio in the model. So that although it wasn't an adverse feature, they still included it because they include the IPI as being an adverse feature. And then you throw in this number of extranodal involvement of greater than 1, which is part of the IPI, and kidney or adrenal involvement. So it is a very confusing model, I've got to say, and realize that in the German analysis, both skin and adrenal-renal were both important prognostic features. And in the BCACA group, marrow involvement and there's testis, orbit, and pericardium were also adverse features. However, they chose adrenal-renal because they were the common denominator in both of those studies. That's how adrenal-renal disease was suggested. Notice that for adrenal-renal in this analysis by the Germans, that the involvement was the highest as far as a single site predicting involvement might be concerned. It was also elevated. The risk of CNS by number of factors in both studies was about the same, so there was a good fit. 40 to 60% of the patients, however, are in the intermediate risk group. Understand that, and they may or may not, that's just, notice that that's a low number down at the bottom, may or may not need CNS prophylaxis. The number is still in the range of 5% or so. So this is, I'm just showing you this again to show you that pretty much everyone has come up with, at least I'll show you the German study, the Canadian study. There's a Danish analysis. Notice that this intermediate group has stayed pretty much the same, and there's a Canadian analysis that I think I'm showing you in a moment. Here, Dr. Puckrin has just presented recently some of their data, and the high-risk patients are all above 10% or so in that range. So this might be a good way of picking out that by using the CNS IPI, and I think we all use that these days in order to predict which patients have the higher risk. But understand and recognize that it is renal or adrenal involvement, not testis and not breast and not any of the other sites that we all traditionally know are bad sites of disease, including sinus and marrow and others. This is Dr. El Galali's study from European that was published a number of years ago. It was a large number of patients that were looked at for a number.
Dr. Hagemeister, again, it's you're not audible, Dr. Hagemeister.
Let's see.
It's fluctuating.
Do you want to change your mic?
I don't have the mic on. Actually, I'm just using my screen. Let me pull it a little closer.
Yeah,
I think you just be closer to it. That should work.
Okay. Yeah. Okay. So about 15% of these had systemic disease on initial diagnosis, and systemic relapse occurred in 32%. Notice that testis, uterus, renal, adrenal, and in high LDH all independently predicted CNS relapse. And as well, at the bottom, you can see that the curves are fairly similar for those which I showed you before. That's a CNS IPI. But when you threw in number of extranodal sites, it changed. And this very, very high risk occurred in patients who had 4 or more extranodal sites of involvement. So I think number of extranodal sites seems to make some sense. Exactly where the cutoff is when you're using the CNS IPI, I don't really know. And it's not a part of the CNS IPI, except that it happens to occur. It's in the CNS IPI, but it's not statistically important. Risks after receiving systemic methotrexate, intrathecal methotrexate, or no prophylaxis were all very similar. So in this study, there was no benefit by giving intrathecal therapy or high-dose methotrexate. This is Dr. Klanova's data that showed what the risk of developing CNS relapse was in Goya. And in this trial, those patients who had a high-risk CNS IPI and had ABC or unclassifiable disease by COO had the highest risk, and that's the red line down there with the risk of 15.2%. The intermediate risk group of patients were those who either had a high CNS IPI or had ABC or unclassified by a cell of origin. And then the low-risk patients down at the very bottom of those who had neither. Well, that's very helpful, and I think it's something that we might have to consider when we start looking at the CNS IPI. Realize that at least from the standpoint of doing analyses, this would help us understand a little bit more about how we're able to better select patients or at least make some sense out of some of the studies that are out there and that have reported results in these patients. This is the outcomes of various different studies that have been reported. I just want to show you this slide only to show you that there have been only really 2 trials, or I should say retrospective analyses, that at that time in 2015 had looked at treatment with therapy other than R-CHOP and whether there was a benefit of R-EPOCH or a hyper-CVAD or CODOX-M IBAC was not exactly clear at that time until Dr. Oki presented from our center 129 patients all treated at our center who were all double hit. CNS involvement was present at diagnosis in 10%, high beta-2 microglobulin in 78%, and a high serum LDH in 69%. So yes, they do have worse features. And at least in our series, about 10% presented with a CNS involvement. CR was achieved in 40% only and with R-CHOP, 68% with R-EPOCH or our hyper-CVAD, which was significant. By multivariate analysis, only adverse performance status and marrow involvement were important, and the CNS disease was predicted by those 2 prognostic factors. And shown on the right-hand side are event-free survival by having none, 1, or 2, those 2 factors. By multivariate analysis, our EPOCH was very much superior as far as event-free survival was concerned. Overall survivals were also different, but not statistically so. So our EPOCH became, at that point in time, considered the regimen to use for patients with double-hit lymphomas. This is another analysis that was presented and published at approximately the same time. They were actually reported very much the same time. Ours came out first, and then this one came up. This one was published in Blood. It's a larger group of patients from 23 different centers, not a single center. However, these 4 prognostic factors, advanced disease, leukocytosis, positive CSF, and an LDH greater than 3 times upper limit of normal. I think that's really interesting because you've already seen that before in the NCCN IPI, that having a high serum LDH was an important prognostic factor determining whether a patient would develop recurrence. By multivariate analysis, those features were all important, but also which was important was intensive treatment. And you can see on the left-hand side is the progression-free survival with more intensive treatment compared to our CHOP. And on the right-hand side was the overall survival by this model which they developed, which suggested that those patients who had all 4 features had a very, very poor chance of being alive. I think this is a really very valuable particular presentation also, because it convinced us at that point that you have to give more intensive therapy other than CHOP for those patients with double hits. This is also a really interesting study which I ran across, which was just published this year. This is looking at patients who had atypical double hits. They're not standard double hits, who have MYC and BCL2 with or without BCL6 rearrangement. Most large cell lymphomas with those rearrangements share a common biology, but atypicals are those that have MYC and BCL2 mutations other than having co-occurring translocations, that is to say, copy number variations. On the left-hand side, they're using overall response, or overall risk, I should say, as being, and this is by hazard ratios. You can see that the risk of developing relapse or CNS relapse when you have a translocated, or at the bottom on the left, or your BCL2 is normal, they're using that as a standard. But if you have any gain of BCL2, either minor gain or major gain, or going up in the little right, in the circle on the left-hand side, and if you have both translocated, it's very high, and you can see that the hazard ratio goes up significantly. However, if you happen to have translocated BCL2, it doesn't matter what's going on with MYC, whether it's normal gain or gained a lot. Or there's high gains. It's only if they are translocated, both translocated. So what MYC and BCL2 are doing together is very important, but even MYC rearranged by itself with some sort of BCL2 abnormality plays a higher risk in patients developing relapse. I think that's an interesting finding. This is a model score that was also identified two groups of patients from 157 patients who are known as double hit signature negative and positive. And this was a double hit signature that was invented by this particular group using various genes to come up with these signatures. And time to progression, overall survival were compared with those with ABC, DLBCL from the British Columbia group treated with R-CHOP. And on the left-hand side, you can see that the time to progression for those patients who have a double hit signature negative did much better. And those patients who had double hit signature positive did approximately the same as those patients who had ABC, DLBCL, not only from the standpoint of time to progression, but also overall survival. They were also compared with another group as well. These are some pathologic and some genetics and pathogenesis of large cell lymphoma. This is one of the questions that was actually asked that you had. There were 574 biopsy samples. There are others that have come up with this MCD analysis and using 372 genes with various methods that are quite technical. 4 different subtypes were identified. Notice that the 5-year overall survival was in fact worse for those patients who had MYD88 and CD79B double mutations. Those patients who had Notch2 mutations or BCL fusion or EZH2 mutation or BCL2 translocation actually did not do very badly. So the MCD happened to do the worst. The Notch1 mutation is a relatively small group. Nonetheless, the correlations are shown at the bottom and may imply therapy, especially for those with the BN2 and the EZB subtype. But MCD double mutation and CD79B is particularly bad. This is a model score so both this LymphGen, this is another study that looked at this MCD analysis with this LymphGen MCD, which you can obtain, as well as a novel hierarchical classification MCD analysis. And they were both prevalent and studied in CNS and systemic relapse. And the results were confirmed in 2 very large cohorts. Shown on the left-hand side are those patients with relapse or systemic disease. Both had disastrous outcomes in this particular analysis from time to progression and overall survival. But what's really interesting is that MCD by either method had a higher risk. You can see with the bar graph, sort of just to the left of the middle, that the risk of CNS relapse was highest in that particular group with the MCD group. I'm not showing you the other analyses, just that one. The others didn't make any difference. Their hierarchical classification MCD consisted of more than three of the other different abnormalities that I showed you here. And I think that's one of the most important takeaways from that particular study. How do you diagnose relapse? I'm not going to even talk about CTs or MRIs or PET scans. I'm going to instead talk about ctDNA because I think that's what's ultimately going to be what will be able to help us make that diagnosis. This is in large cell lymphoma. If you see a 2-log drop in ctDNA following one cycle of therapy, the event-free survival in the training cohort and the validation cohort were very, very obvious that having achieved early molecular remission is an important attainment in the peripheral blood for patients who are treated with large cell lymphoma. This is for systemic relapse. This is for CNS relapse. This is 19 patients who've been analyzed by next generation sequencing, MRD status, and it turns out that 2 patients in this analysis had CNS relapse, and both of them had cell-free DNA in the CNS at the time of diagnosis. Both of them received intrathecal prophylaxis, indicating that it didn't help them at all, that the cell-free DNA was the way really to determine that. And I think this is what we're going to have to figure out in the future and make this more of a way to predict these kind of recurrences. What about rituximab as being a therapy for these patients? It, of course, can be given intrathecally, but whether it helps or not is not clear. There was no benefit in the JLS study of the classic R-CHOP versus R-CHOP in CNS relapse noted when patients received rituximab. Rituximab did reduce overall CNS relapse from 6.9 to 4.1% in the RECOVER-60 trial. In British Columbia, the benefit of R-CHOP was only noted in patients who actually went into complete remission. So there's a lot of distrust on my part. We're giving rituximab to everybody anyway, so what difference does it matter? Other regimens that are more intensive than R-CHOP may reduce CNS relapse, but they have not been proven to reduce it in systemic relapse rates in randomized studies. Realize that there are very few double hits that were enrolled in our EPOCH R-CHOP trial. This is prophylaxis using intrathecal methotrexate. I'm not showing you, there's so many studies that have been reported using intrathecal methotrexate, and this is a group of patients, 372, who achieved CR, and they had an LDH that was greater than 2 times normal, mass greater than 10 centimeters, performance status greater than 1, or one of those extranodal sites that you're familiar with. 4 doses of intrathecal methotrexate were given after CR. There was an isolated CNS relapse in 11. It was actually a higher CNS relapse rate for those patients who received the intrathecal methotrexate. So that's no way to give the therapy at the end of treatment. An earlier report, this is important because an earlier report from this group did suggest that a lower CNS relapse rate was achievable with giving intrathecal methotrexate. Skin involvement and more than one extranodal site of involvement suggested that you were going to get a CNS relapse. These are studies that have looked at high-dose methotrexate, and again, many different trials or reports of patients. However, most of them are not prospective studies. This includes some patients who are not on prospective studies and some were. You can see that there were different regimens administered. Pay attention to the one at the bottom, the Italian study, which gave only R-CHOP. It was the highest risk group of patients were those patients who received no intravenous methotrexate. And the same is true of their high-risk patients who are in Australia, that those received none had an 18.4% of risk of developing CNS involvement. And high-dose methotrexate and intrathecal brought it down to the lowest. I think that's I think it may be that the risk overall is somewhere between 3 and 8% for the average patient. It's just very difficult to tell. And from these studies, it is also difficult to tell whether high-dose methotrexate really does anything or not, because in some studies, it showed some benefit, and at least in these, it did, but there are some that didn't. This was an interesting trial that was reported in 2018. It's a retrospective analysis that was reported in leukemia lymphoma, 480 patients with risk, as you see in the second bullet. The patients received CHOP or R-CHOP-like therapy and at least 2 cycles of high-dose methotrexate. There was no CNS disease at diagnosis, and nobody was over 75. High-dose methotrexate in this study improved systemic progression-free survival and overall survival, but did not prevent CNS relapse. That's exactly the opposite as to what we would think. And when they looked at the different prognostic factors, you can see in the box on the right-hand side that high-dose methotrexate was associated with a lower risk of relapse, but not CNS relapse. So I don't understand that particular outcome. Rituximab was also associated with a lower risk of systemic relapse, of course. So I think it's an interesting observation, and it throws some light onto whether methotrexate really works. So this study also looks at, conducted a multivariate analysis controlling for CNS IPI, double hit, and testis involvement. And patients were defined from this group in Canada by their own criteria. They have guidelines and their own criteria that were developed. And notice that high-dose methotrexate did absolutely nothing to prevent CNS relapse, progression-free survival, or overall survival in this group of patients. This was published this year. Intensive chemotherapy, likewise, did nothing for those 3 different endpoints. Autologous stem cell transplant did, in particular. It helped with CNS relapse. It also, of course, prevented patients from progressing or having overall survival. But that is a skewed population, a selected group of patients who have to have achieved a CR and don't fail early. So if you do get a patient who is in remission and can get a stem cell transplant, it might be of some value to prevent CNS relapse. But of course, there have been other studies that have suggested only patients with very high-risk disease by IPI should be subjected to stem cell transplant up front. This is also further data from that same group, from the group published last year, showing that prophylactic high-dose methotrexate did nothing to prevent CNS relapse, with intensive chemotherapy or auto-transplant doing something to prevent CNS relapse. With consolidative auto-transplant, there was a difference in this study, but not statistically. This is CNS relapse by CNS IPI in a paper that was presented at ASH last year. It is not in print yet. Notice, and I'm not showing you all of the things that they showed. These are only serum LDH and number of extranodal sites. I keep coming back to the number of extranodal sites as being adverse. Notice from the curves on the lower hand side that that's the CNS IPI, and the linear regression for this is 0.01. So it was significant. But look at that moderate intermediate group. It does approach at 5 years or so that risk for those patients who had high risk. Liver involvement and testicular and not renal or adrenal involvement were associated with CNS relapse. The impact of prophylaxis is not clear. This is looking at that matched analysis. Intrathecal prophylaxis made no difference in this group, and intravenous methotrexate made no difference in this group. There are drugs that are known to significantly cross the blood-brain barrier, and they include isofosfamide, which is surprising to me, carboplatin, BCNU, idarubicin, cladribine, and lomustine. So not surprising that BCNU and CCNU are used in autologous stem cell transplant programs. So prior studies of secondary CNS lymphoma reported poor overall survivals. So this was a phase 2 trial that led up to the most recent Marietta study. There were 38 patients who had secondary CNS lymphoma, 16 were at original diagnosis, and 2 patients with systemic involvement received 1 cycle of R-CHOP first. Induction consisted of high-dose methotrexate Ara-C, and then they received intensification with cyclophosphamide and Ara-C, and then high-dose etoposide was given for those with systemic involvement. Notice that these patients did not receive any anthracycline. Then they got a transplant, and there was not a bad result. That's all I can say right now at this point. The complete response after induction was 26%. That's really surprising for me. And after the intensification, it goes up to 58%, which is a little bit more understandable because they're giving drugs that work against systemic large cell lymphoma. All 20 patients who underwent stem cell transplant had entered CR and were still free of disease out at 4 or 5 years of follow-up. I think that's very interesting that the overall survivals and event-free survivals were as good as they were in this particular group of patients. So brings us to the Marietta Trial, which was just published. This is one of the more interesting and amazing studies that I've seen most recently. It's a phase 2 trial conducted in 24 hospitals in 4 countries. 75 patients were collected. They were run out of Italy. These patients had secondary CNS lymphoma, 32 at original diagnosis, 43 at relapse. 15 of them had isolated CNS relapse. So these were not primary CNS patients unless they had developed recurrent disease. Their features are shown here: more than one extranodal site, not CNS, was in 31% of the patients, and having refractory disease in 27%. This is a bad risk group of patients. Patients received 3 cycles of R high-dose methotrexate Ara-C, and then 3 cycles of RICE, and then BCNU, thiotepa, and a stem cell transplant. I think the most interesting thing about this trial is this is the first time that I have seen patients enrolled at initial diagnosis separated from those who enrolled at relapse. And you can see on the right-hand side that progression-free survival wasn't very good for those who were enrolled at relapse, but that should be somewhere around 6 months or 8 months that most of those patients would have progressed. So this might be a better analysis, a better method of treatment. I don't know for those particular patients. I do know for those who are initially diagnosed and treated on this program, this is excellent results. And it should be something that we perhaps should adapt in our practice. For those who enrolled at relapse, it's difficult to say that that is much better, but I think it is better. There is certainly going to be a trend for it to be better. I do want to discuss in the last few minutes that I've got, I know I've run over, that this is a study of 45 patients who had refractory relapsed primary CNS or vitreoretinal lymphoma. They did not have systemic disease. They received a standard R-squared therapy with lenalidomide. The complete response rate after 4 cycles of therapy was 36%. This means that patients should receive lenalidomide perhaps at the time of recurrence, or should have that available as a choice at the time of recurrent disease. Whether it belongs in combination with other therapies is not clear. The progression-free survival was also better for those with a higher CD4-CD8 ratio by using a ROC curve. The ibrutinib is also an important drug in the management of these patients. I believe this is a phase 1 study of high-dose methotrexate along with the ibrutinib, and it included 9 primary CNS and 6 secondary CNS lymphomas. 3 out of 6 were newly diagnosed. Overall response rate was 80%, 89% for those with primary CNS, and 67% for those with secondary. The median PFS, unfortunately, was 9.2 months, but all 5 who underwent stem cell transplant were NED. And this is also an important study in that they began using ctDNA studies to show responses in these patients. Other drugs that might be important include temozolomide, an old drug that achieved a sort of lower response rate, pemetrexed, which is used in China and has been studied there, Cns Relapse, as well as nivolumab. The nivolumab data is real interesting. We have a trial that is ongoing giving nivolumab and ibrutinib together. We've collected 10 patients so far with isolated CNS relapse, and we've seen good responses. We have not completed the trial as yet. So a few comments also about TNF alpha. This is an important cytokine that alters cell-cell adhesion. It increases vascular permeability of the blood-brain barrier, but it is toxic. This particular peptide recognizes CD13, which is upregulated on angiogenic tumor vessels, much greater than normal vessels. So CD13 is found on angiogenic tumor vessels, which are important for keeping those tumors alive. A fusion product of these two targets, of these two particular things, the peptide as well as TNF alpha, targets tumor vessels and localized drugs to brain and other tumors. 34 patients were enrolled after high-dose methotrexate failure. 12 had failed matrix. 12 of these patients had progressive disease with initial therapy and 19 were considered refractory. Based on this, they began giving this in combination with CHOP. This is the data looking at those patients, and it suggests that you might be able to use this as initial therapy. The overall response rate was 75%, and 39% had a CR. CAR Ts are also being used as well, and this was data that's the only one that I know is published in this study. There were 9 patients who had secondary CNS involvement, and 4 of those patients achieved CR and are still lasting. There was some transient neurotoxicity that occurred in only 1. There was concern about neurotoxicity and confusion with the disease. So the best factor, these are my conclusions, the best factor for CNS relapse is the presence of more than one extranodal site. The CNS IPI is reasonable to use, but other features also have to be considered, including this LDH greater than 3 times upper limit of normal, specific sites that you might see, as well as double hit. Everybody gets rituximab, so it is really not an issue. Intrathecal prophylaxis, all these drugs may help to clear the CSF, including thiotepa, liposomal Ara-C, and rituximab. But those patients will eventually develop disease progression in the CNS. So I don't expect that they're very good therapies for patients to prevent disease. High-dose therapy is also prophylaxis, has been included in hyper-CVAD, Codax, and other regimens are better at preventing relapse and double hits and might be useful in preventing CNS relapse. We just don't know. But high-dose methotrexate can be incorporated with R-CHOP and EPOCH-R, but its value is also still controversial. So I'm going to say standard treatment for secondary CNS involvement has improved and should include high-dose methotrexate and high-dose. We know that. And consolidation with brain radiation therapy, maybe low dose, and stem cell transplant should be considered. It's still very difficult to prove. Therapy for it remains challenging. Both CNS and systemic treatment is required. Autologous stem cell transplant should be strongly considered for these patients in CR. And whole brain radiation therapy may be useful, and there are novel agents that are being developed. I would be happy to answer questions during the question and answer period that I think Dr. Vish is going to present, has some questions. Thank you.
Yeah. Thank you, Dr. Hagemeister, for that wonderful and insightful talk. I think all of us, including our fellows, have learned a lot from your talk. So let's move on to the next session, the most awaited session, that is the interactive session of the residents and fellows with the professor. So let me make the rules clear. We have 11 residents here, and let's make it 2 minutes per resident. They will ask a question, and Dr. Hagemeister can give an answer which can be within 2 minutes, and then that way we can run through around 11 questions from 11 different.
We have either ABC or GCB type large cell lymphoma. It doesn't appear to reduce the risk of relapse, although this American trial has suggested it, and there is an ongoing study that's going to collect a lot more patients to try to sort out which patients those are. I personally think that lenalidomide as maintenance therapy might be useful in some of those patients who have large cell lymphoma for whom you know you're not going to be able to do a stem cell transplant ultimately. I don't know that lenalidomide is good as prophylaxis for those patients up front or in relapse for CNS involvement. I don't think that has been fully worked out. And I just want to preface, I was going to say before the question and answer period began, I did discuss these questions a little bit with Dr. Vish, and I told him I don't know the answer to any of these questions.